This recorded lecture will be going over Unit 4 in the ATI PN Mental Health Nursing textbook. This will cover chapters 21 through 26. Beginning with chapter 21, medications for anxiety and trauma and stressor-related disorders. Major medications to treat anxiety disorders include benzodiazepine sedative hypnotic anxiolytics, such as lorazepam, alprazolam, clonazepam, diazepam, clorazepate, chlorazidioxide, and oxapam. Atypical anxiolytic or non-barbiturate anxiolytics, such as buspirone. Select antidepressants, such as SSRIs and SNRIs. Additional classifications that can be used include other antidepressants, such as tricyclic antidepressants, monoamine oxidase inhibitors, mirtazapine, and trazodone. Antihistamines, beta blockers, centrally acting alpha blockers, and anticonvulsants. Major medications to treat trauma and stressor-related disorders include antidepressants, such as selective serotonin reuptake inhibitors, paroxetine, sertraline, fluoxetine, escitalopram, and fluvoxamine. Serotonin norepinephrine reuptake inhibitor, such as venlafaxine. Tricyclic antidepressants, such as amitriptyline and imipramine. MAOIs, such as phenelzine. Noradrenergic and specific serotonergic antidepressants, such as mirtazapine. Beta blockers like propranolol. Peripherally acting alpha blockers, such as prazosin, or centrally acting alpha-2 agonists, such as clonidine. Benzodiazepine sedative hypnotic anxiolytics. The selected prototype medication that we'll be discussing for this section is alprazolam. The therapeutic use of this medication is the short-term treatment for generalized anxiety disorder and panic disorder. It can also be used for seizure disorders, insomnia, muscle spasm, alcohol withdrawal, induction of anesthesia, or amnesic prior to surgery or procedures. Complications of alprazolam include central nervous system depression, CNS depression is evidenced by sedation, lightheadedness, ataxia, and decreased cognitive function. Patient education includes avoiding hazardous activities, such as driving, operating heavy machinery or equipment, and avoiding concurrent use of alcohol and other CNS depressants. Another complication is anti-retrograde amnesia. This is difficulty recalling events that can occur after dosing. Patient education includes withholding the medication if these effects occur. Acute toxicity. Oral toxicity can present as drowsiness, lethargy, and confusion. IV toxicity will present as respiratory depression, severe hypotension, or cardiac arrest. Benzodiazepines for IV use include diazepam and lorazepam. Nursing actions. Flumazenil can be administered to counteract sedation and reverse the adverse effects. Monitor vital signs, maintain a patent airway, and provide fluids to maintain blood pressure. Ensure availability of resuscitation equipment. A paradoxical response is evidenced by insomnia, excitation, euphoria, anxiety, and rage. Withdrawal effects from alprazolam include anxiety, insomnia, diaphoresis, tremors, lightheadedness, delirium, and seizures. This will occur infrequently with short-term use. Patient education. After taking benzodiazepines regularly and in high doses, you must taper the dose over several weeks using a prescribed tapered dosing system. Contraindications for alprazolam and benzos. Benzodiazepines are classified under the Schedule 4 of the Controlled Substances Act. Benzodiazepines are contraindicated in patients with sleep apnea, respiratory depression, and/or glaucoma, as well as patients with a history of liver disease or a substance use disorder. Benzos are generally not used for short-term use due to the risk of dependence. and be sure to monitor the fall risk for older adult patients prescribed benzodiazepine. CNS depressants can cause respiratory depression when interacted with benzodiazepines, so avoid any hazardous activities. Nursing administration. Administer this medication with meals or snacks if GI upset occurs. Do not change the dosage or frequency without approval of the prescriber. Keep benzodiazepines in a secure place due to the potential for misuse. Dependency can develop during and after treatment. Notify the provider if indications of withdrawal occur. Atypical anxiolytic non-barbiturate anxiolytics. The selected prototype medication for this section is buspirone. Therapeutic uses are for generalized anxiety disorder. Complications. CNS effects include dizziness, nausea, headache, lightheadedness, and agitation. It does not cause sedation. Contraindications. Use buspirone cautiously in patients with liver or kidney dysfunction. Buspirone is contraindicated for concurrent use with MAOI antidepressants or for 14 days after MAOIs are discontinued. Hypertensive crisis can result. Erythromycin, ketoconazole, kava, valerian, chamomile, and grapefruit juice will all increase the effects of buspirone, so avoid all of them. Nursing administration. Medication should be administered at the same time every day. These effects will not occur immediately. It can take up to 1 week to notice the first therapeutic effects, and up to 4 weeks to reach full therapeutic effect. Medication should be taken on a regular basis rather than an as-needed basis. Tolerance, dependence, or withdrawal manifestations are not an issue with this medication. Selective serotonin reuptake inhibitors. For the purpose of this section, our selected prototype medication is paroxetine. Therapeutic uses. SSRI antidepressants are the first-line treatment for panic disorders and trauma and stressor-related disorders. Paroxetine, sertraline, citalopram, escitalopram, fluoxetine, and fluvoxamine. Complications of SSRIs include early adverse effects and later adverse effects. The early adverse effects will occur within the first few days and weeks and present as nausea, diaphoresis, tremor, fatigue, and drowsiness. These effects should soon subside, but the patient should avoid driving if any of those effects occur. Later adverse effects will occur after 5 to 6 weeks of therapy and can include sexual dysfunction, weight gain, and headache. Report these problems to the provider. Weight changes. The occurrence of weight loss early in therapy can be followed by weight gain with long-term treatment, so the patient should follow a well-balanced diet and exercise regularly. GI bleeding. Use this cautiously in patients with a history of GI bleed, ulcers, or taking medications that affect blood coagulation, and the patient should be educated to report any indications of bleeding. Hyponatremia. This is more likely in the older adult taking diuretics. Obtain a baseline blood sodium and monitor the levels periodically during treatment. Serotonin syndrome. This can begin 2 to 72 hours after starting treatment, and this can be lethal. Manifestations of serotonin syndrome include confusion, agitation, poor concentration, hostility, disorientation, hallucinations, delirium, seizures leading to status epilepticus, tachycardia leading to cardiovascular shock, labile blood pressure, diaphoresis, fever leading to hyperpyrexia, incoordination, hyperreflexia, nausea, vomiting, diarrhea, abdominal pain, and coma leading to apnea and death in severe cases. Patients should be educated to observe for any of those manifestations, and if they occur, withhold the medication and notify the doctor immediately. Bruxism. This is grinding and clenching of the teeth that typically occurs during sleep. Patients should be educated to use a mouth guard during sleep. Withdrawal syndrome will present as nausea, sensory disturbances, anxiety, tremor, malaise, and unease. Patients should be educated to taper this medication slowly and avoid any abrupt discontinuation of the medication. Contraindications. SSRIs are contraindicated in patients taking MAOIs or TCAs. Clients should avoid any alcohol when taking SSRIs, and use SSRIs cautiously in patients with bipolar disorder due to the risk of mania. Concurrent use of TCAs, MAOIs, or St. John's wort will cause serotonin syndrome. Concurrent use with warfarin can displace warfarin from bound protein and result in increased warfarin levels. The nurse should monitor the PT and INR levels, as well as any indications of bleeding or the need for dosage adjustment. Concurrent use with TCAs and lithium can result in increased levels of these medications. Concurrent use with NSAIDs and anticoagulants can further suppress platelet aggregation, thereby increasing the risk of bleeding. Patients should be educated to monitor themselves for any indications of bleeding, such as bruising or hematuria, and notify the provider if they occur. Nursing administration. SSRIs can be taken with food. Sleep disturbances are minimized by taking the medication in the morning, and it can take up to 4 weeks to achieve therapeutic effects. Serotonin norepinephrine reuptake inhibitors. For the purpose of this section, our select prototype medication is venlafaxine. The therapeutic use. It is used for major depression, panic disorders, and generalized anxiety disorders. Complications include a headache, nausea, agitation, anxiety, dry mouth, and sleep disturbances. Hyponatremia, especially in our older adult patients taking diuretics. Anorexia, resulting in weight loss. Hypertension, sexual dysfunction, suicidal thoughts. Serotonin syndrome. Contraindications. SNRIs are contraindicated in patients taking MAOIs. Patients should be educated to avoid abrupt cessation of the medication, as well as to avoid alcohol while taking any SNRIs. Concurrent use of MAOIs and John's wort will cause serotonin syndrome. CNS depression with alcohol, opioids, antihistamines, and sedative hypnotics could occur. Concurrent use with NSAIDs and anticoagulants can further suppress platelet aggregation and increase the risk of bleeding. Nursing administration. SNRIs can be taken with food. Medication can take up to 4 weeks to achieve therapeutic effects. Nursing evaluation of medication effectiveness. Depending on the therapeutic intent, effectiveness is evidenced by the following: verbalized feelings of less anxiety, description of improved mood, improved memory retrieval, maintenance of a normal sleep pattern, greater ability to participate in social and occupational interactions, improved ability to cope with manifestations and identified stressors, ability to perform activities of daily living, reports of increased well-being. Chapter 22, Medications for Depressive Disorders. Advise clients starting antidepressant medication therapy for a depressive disorder that relief will not be immediate. It can take several weeks or longer to reach full therapeutic effects. Encourage continued compliance. Antidepressant medications can be classified into 5 main groups. A combination of antidepressant medications can be required to alleviate all manifestations. Tricyclic antidepressants. Our select prototype medication is amitriptyline. The therapeutic use is for depressive disorders, but other uses include neuropathic pain, fibromyalgia, anxiety disorders, insomnia, bipolar disorder, obsessive-compulsive disorder, and attention deficit hyperactivity disorder. Complications include orthostatic hypotension. The nurse should monitor blood pressure and heart rate for any orthostatic changes. The patient should be educated to change position slowly and avoid dehydration. Anticholinergic effects include dry mouth, blurred vision, photophobia, urinary hesitancy or retention, constipation, and tachycardia. Patients need to be educated on methods to minimize these anticholinergic effects. This would include chewing on sugarless gum, sipping on water, wearing sunglasses when outdoors, eating foods high in fiber, exercising regularly to promote peristalsis, increasing fluid intake to 2 to 3 liters per day from beverage and food sources, voiding just before taking the medication. Sedation is a complication, and this adverse effect will typically diminish over time. Patients should be educated to take the medication at bedtime to minimize any daytime sleepiness and promote their sleep. Another complication is toxicity. This can result in a cholinergic blockade and cardiac toxicity evidenced by dysrhythmia, mental confusion, and agitation, which are then followed by seizures, coma, and possibly death. Nurses should obtain a baseline EKG, monitor vitals frequently, and monitor for any manifestations of toxicity. Another complication is a decreased seizure threshold, excessive sweating, increased appetite. This medication is contraindicated for patients with seizure disorders, and TCAs can increase a suicide risk. Concurrent use with MAOIs can cause severe hypertension. Concurrent use with antihistamines and other anticholinergic agents can result in additive anticholinergic effects. Concurrent use with direct-acting symphomimetics can result in increased effects by these medications because uptake is blocked by TCAs. Concurrent use with indirect-acting symphomimetics can result in decreased effect of these medications. Concurrent use with alcohol, benzodiazepines, opioids, and antihistamines can result in additive CNS depression. Selective serotonin reuptake inhibitors. Our select prototype medication is fluoxetine. Therapeutic uses include major depression, obsessive compulsive disorder, bulimia nervosa, premenstrual dysphoric disorders, panic disorders, post-traumatic stress disorder, bipolar disorder, generalized anxiety disorder, and social anxiety disorder. Complications of this medication include sexual dysfunction, evidenced by anorgasmia, impotence, and decreased libido. Methods to manage sexual dysfunction can include lowering the dosage, discontinuing the medication temporarily, known as a medication holiday, and using adjunct medications to improve the sexual function. Another complication is CNS stimulation in the forms of insomnia, agitation, and anxiety. Instruct the patient about how to use relaxation techniques to promote their sleep. Patients should be educated to take this medication in the morning and avoid any caffeinated beverages. Another complication is weight changes. There can be an occurrence of weight loss early in therapy that can then be followed by weight gain with long-term treatment. Patients should be encouraged to participate in a regular exercise regimen and to follow a healthy, well-balanced diet. Serotonin syndrome can begin 2 to 72 hours after the start of treatment, and it can be lethal. Nursing actions include starting symptomatic treatment. These are medications to create a serotonin receptor blockade and muscle rigidity. Includes cooling blankets, anticonvulsants, and artificial ventilation. Withdrawal syndrome is evidenced by a headache, nausea, visual disturbances, anxiety, dizziness, and tremors. Hyponatremia is more likely to occur in the older adult taking diuretics. A rash can be treatable with an antihistamine or discontinuing a medication. Sleepiness, faintness, and lightheadedness is a complication. These adverse effects are not common, but they can occur. The patient should avoid driving if any of these effects occur. The patient should avoid driving if any of these effects occur. GI bleeding and bruxism are other complications. Contraindications. These medications are contraindicated in patients taking MAOIs or TCAs. Concurrent use with MAOIs or TCAs or St. John's wort will increase the risk of serotonin syndrome. Concurrent use with warfarin can displace warfarin from bound protein and result in increased warfarin levels. Concurrent use with tricyclic antidepressants and lithium can result in increased levels of these medications. Concurrent use with NSAIDs and anticoagulants can further suppress platelet aggregation, thereby increasing a risk of bleeding. Serotonin norepinephrine reuptake inhibitors, or SNRIs. We'll be discussing 3 different kinds. Venlafaxine, duloxetine, desvenlafaxine, and levomilnacipran. Nursing actions include monitoring for adverse effects, which are headache, nausea, agitation, anxiety, dry mouth, and sleep disturbances. Monitoring for any increases in blood pressure. This medication should be discontinued gradually. Mirtazapine. These therapeutic effects can occur sooner with this medication and with less sexual dysfunction than SSRIs, and this medication is generally well tolerated. Trazodone. This agent is usually used with another antidepressant agent. Sedation can be an issue, so it can be indicated for a patient with insomnia caused by an SSRI. This medication should be used with caution in patients with cardiac disease, and priapism can be a serious adverse effect. Monoamine oxidase inhibitors, or our MAOIs. Our select prototype medication is phenelzine. Therapeutic uses include depression, bulimia nervosa, first-line treatment for atypical depression, panic disorder, social anxiety disorder, generalized anxiety disorder, obsessive-compulsive disorder, and PTSD. Complications include CNS stimulation, evidenced by anxiety, agitation, hypomania, and mania. Orthostatic hypotension, hypertensive crisis. This can result from an intake of dietary tyramine. Severe hypertension can result due to the intensive vasoconstriction and stimulation of the heart. This is manifested by a headache, nausea and vomiting, increased heart rate, increased blood pressure, diaphoresis, and change in level of consciousness. Patients need to be educated to avoid designated foods while taking this medication. Another complication is a local rash associated with the transdermal preparation. You can apply a topical glucocorticoid on the affected areas if this rash occurs. Contraindications. MAOIs are contraindicated in patients taking SSRIs. MAOIs are contraindicated in patients with pheochromocytoma, heart failure, cardiovascular and cerebral vascular disease, or severe renal insufficiency. Concurrent use with indirect-acting symphomimetic medications can promote the release of norepinephrine and lead to a hypertensive crisis. So patients need to be educated that over-the-counter decongestants and cold remedies will frequently contain these medications with symphomimetic action, and therefore they need to be avoided. Concurrent use with TCAs can lead to a hypertensive crisis. Concurrent use with SSRIs can lead to serotonin syndrome. Concurrent use with antihypertensive can cause additive hypotensive effects. Concurrent use with meperidine can lead to hyperpyrexia. Hypertensive crisis, which is severe hypertension as a result of intensive vasoconstriction and stimulation of the heart, can result from intake of dietary tyramine. Tyramine-rich foods include aged cheese, pepperoni, salami, avocados, figs, bananas, smoked fish, protein, some dietary supplements, some beers, and red wine. Concurrent use with vasopressors can result in hypertension and general anesthetics. Atypical antidepressants. Our select prototype medication is bupropion. Nursing actions include administering it with food to increase absorption, and there is a risk of serotonin syndrome and neuroleptic malignant syndrome while taking this medication. Therapeutic uses include the treatment of depression. It's an alternative to SSRIs for patients unable to tolerate the sexual dysfunction adverse effects. It can be used as an aid to quit smoking and prevention of a seasonal pattern depression. Complications include headache, dry mouth, GI distress, constipation, increased heart rate, nausea, restlessness, and insomnia. We can treat headaches with a mild analgesics, and patients should be educated to sip water to treat their dry mouth and increase dietary fiber to prevent any constipation. Another complication is suppression of appetite resulting in weight loss, seizures, especially at higher dose ranges. Contraindications. This medication is contraindicated for patients with a seizure disorder, as well as patients taking MAOIs. Interactions. Concurrent use with MAOIs can increase the risk of toxicity. There is an increased risk of seizures with the concurrent use of SSRIs. Patient education. Inform the patient that the therapeutic effects may not be experienced for 1 to 3 weeks. Full therapeutic effects can take 2 to 3 months. It's important to continue the therapy after improvement in manifestations. Sudden discontinuation of the medication can result in relapse or major withdrawal effects. Therapy usually will continue for 6 months after resolution of manifestations, and it can continue for 1 year or longer. Suicide prevention is facilitated by prescribing only 1 week of medication for an acutely ill client, and following that, only prescribing 1 month of medication at a time, especially with TCAs, which have a higher risk of lethality with a toxic dose. Monitor the patient for any suicide risk. Antidepressant medications will increase the patient's risk of suicide, particularly during the initial treatment period. Antidepressant-induced suicide is mainly associated with patients under the age of 25. Nursing evaluation of medication effectiveness. Effectiveness of antidepressant medication can be evidenced by the following: verbalizing improvement in their mood, ability to perform ADLs, improved sleeping and eating habits, and increased interaction with peers. Chapter 23, Medications for Bipolar Disorders. Bipolar disorder is primarily managed with mood-stabilizing medications. This is lithium carbonate. Bipolar disorder also can be treated with certain anti-epileptic medications. Anti-epileptic medications for bipolar disorder include valproic acid, carbamazepine, lamotrigine, oxcarbazepine, and topiramate. Other medications used for bipolar disorder include antipsychotics, anxiolytics, and antidepressants. Mood stabilizers. Our select prototype medication is lithium carbonate. The therapeutic uses. It controls the episodes of acute mania and helps to prevent the return of mania or depression and decreases the incidence of suicide. Complications of this medication include GI distress in the form of nausea, diarrhea, and abdominal pain. Advise the patient that GI distress is usually transient, and this can be alleviated by administering the medication with food or milk. Another complication is fine hand tremors. This can be exacerbated by factors such as stress and caffeine. Nursing actions include administering beta-adrenergic blocking agents such as propranolol. Another complication is polyuria and mild thirst. Educate the patient to maintain an adequate fluid intake by consuming at least 1.5 to 3 liters of fluid per day. Another complication is weight gain, renal toxicity. Goiter and hypothyroidism can occur with long-term treatment. Bradydysrhythmias, hypotension, and electrolyte imbalances. Lithium toxicity. This can be a common adverse effect, occurring with a lithium level of less than 1.5. Manifestations include diarrhea, nausea, vomiting, thirst, polyuria, muscle weakness, fine hand tremors, slurred speech, and lethargy. Early indications of lithium toxicity can occur with a lithium level of 1.5 to 2.0. Manifestations include mental confusion, sedation, poor coordination, coarse tremors, ongoing GI distress, including nausea, vomiting, and diarrhea. the patient should be instructed to withhold the medication. Advanced indications of lithium toxicity will occur with a lithium level of 2.0 to 2.5. Manifestations include extreme polyuria of dilute urine, tinnitus, giddiness, jerking movements, blurred vision, ataxia, seizures, severe hypotension and stupor leading to coma, and possible death from respiratory complications. Nurses should administer an emetic to alert clients or assist with administering a gastric lavage. In severe toxicity, the lithium level will be greater than 2.5. Manifestations include rapid progression of manifestations that will lead to coma and death, and hemodialysis can be warranted in this situation. Contraindications. Use these cautiously in older adult patients, as well as patients with thyroid disease, seizure disorder, or diabetes. Interactions can occur with diuretics. Sodium is excreted with the use of diuretics. With decreased blood sodium, lithium excretion is decreased, and that can lead to toxicity. NSAIDs. Concurrent use with NSAIDs will increase renal reabsorption of lithium and lead to toxicity. Patients should be educated to use aspirin instead, as it's a mild analgesic that will not lead to toxicity. Interactions with anticholinergics. Abdominal discomfort can result from anticholinergic-induced urinary retention and polyuria. Nursing administration. Monitor the plasma lithium levels while undergoing treatment. Lithium blood levels should be obtained in the morning, about 10 to 12 hours after the last dose. Advise the patient that the effects will begin within 5 to 7 days, and maximum benefits may not be seen for 2 to 3 weeks. Taking lithium with food will help decrease GI distress. Reinforce nutritional counseling, and stress the importance of adequate fluid and sodium intake. Mood-stabilizing anti-epileptic medications. Our select prototype medications include carbamazepine, valproate, and lamotrigine. Therapeutic uses. These medications are used to treat and prevent relapse of manic and depressive episodes. They are particularly useful for clients with mixed mania and rapid cycling bipolar disorders. Complications. Carbamazepine has minimal effect on cognitive function. It can have CNS effects, such as nystagmus, double vision, vertigo, staggering gait, and a headache. Patients should be educated that these effects will subside within a few weeks. Blood dyscrasias. This can include leukopenia, anemia, and thrombocytopenia. Nurses should obtain a baseline CBC and platelets, as well as perform ongoing monitoring of these levels. Observe for any indications of thrombocytopenia, including bruising and bleeding of gums, and monitor for any indications of infection, including fever or lethargy. Another complication is hypoosmolarity. Nurses should monitor for any edema, a decrease in urine output, and hypertension. Another complication is skin disorders. This includes dermatitis and a rash, such as Stevens-Johnson syndrome. Patients should be educated to wear sunscreen to reduce the chance of any skin disorders. Lamotrigine. Complications include double or blurred vision, dizziness, headache, nausea, vomiting, and serious skin rashes. Valproate. Complications include GI effects, hepatotoxicity, and pancreatitis, thrombocythemia, and weight gain. Contraindications. Carbamazepine is contraindicated in patients with bone marrow suppression or bleeding disorders. Interactions. Carbamazepine can interact with oral contraceptives and warfarin. Patients should be educated to use an alternate form of birth control. Grapefruit juice will inhibit the metabolism of carbamazepine, thereby increasing blood levels of the medication. Concurrent use of other anticonvulsants will decrease the effects of carbamazepine by stimulating metabolism. Lamotrigine. Carbamazepine, phenytoin, phenobarbital will all lead to concurrent use, decreasing the effect of lamotrigine. Concurrent use of valproate will inhibit drug metabolizing enzymes, thereby increasing the half-life of lamotrigine. Concurrent use of oral contraceptives will decrease the effectiveness of both medications, so patients should be educated to use an alternate form of birth control. Complications, interactions with valproate include concurrent use of other anticonvulsants that can affect the blood levels of the valproate. Nursing evaluation for medication effectiveness. Depending on the therapeutic intent, effectiveness can be evidenced by the following: relief of acute manic manifestations, verbalization of improvement in mood, ability to perform ADLs, improved sleeping and eating habits, appropriate interaction with peers. Chapter 24, Medications for Psychotic Disorders. Schizophrenia spectrum disorder is the primary reason for the administration of antipsychotic medications. Manifestations. Medications are used to treat positive symptoms and negative symptoms. The goals of psychopharmacological treatment for schizophrenia and other psychotic disorders include suppression of acute episodes, prevention of acute recurrence, maintenance of the highest possible level of functioning. First-generation antipsychotics are medications used mainly to control positive symptoms of psychotic disorders. These are typically reserved for patients who are using them successfully and can tolerate their adverse effects, and also are concerned about cost associated with second-generation antipsychotic medications. First-generation agents are classified as either low, medium, or high potency, depending on their association with extrapyramidal symptoms, or EPS, their level of sedation, and their anticholinergic adverse effects. Second-generation antipsychotics. These agents are often chosen as a first-line treatment for schizophrenia. They are more effective than first-generation antipsychotics, and they have fewer adverse effects. Advantages of second-generation antipsychotics include relief of positive and negative symptoms, fewer or no EPS, including tardive dyskinesia, fewer anticholinergic effects, and less relapse. Third-generation antipsychotic agents are used to treat positive and negative symptoms while improving cognitive function. Antipsychotics, first generation or conventional. Our select prototype medication will be chlorpromazine, low potency. Therapeutic uses. For the treatment of acute and chronic psychotic disorders, schizophrenia spectrum disorders, bipolar disorder, Tourette's disorder, agitation, prevention of nausea vomiting through blocking of dopamine in the chemoreceptor trigger zone of the medulla. Complications include agranulocytosis. If any indications of infection appear, the nurse should obtain a CBC, and the medication should be discontinued if the white blood cell count is less than 3,000. Another complication is anticholinergic effects. Extrapyramidal adverse effects include acute dystonia. This is manifested by severe spasm of the tongue, neck, face, and back, and crisis situation that can require rapid treatment. Nurses should stay with the patient and monitor the airway until the spasms subside, which typically lasts 5 to 15 minutes. Pseudoparkinsonism is another EPS symptom. Manifestations include bradykinesia, positive symptoms of schizophrenia, rigidity, shuffling gait, drooling, tremors inducing pill rolling, and mask-like face. This can occur in 5 to 30 days following the first dose, and nurses need to implement interventions to reduce the risk of falling. Akathisia is another symptom of experimental adverse effects. Manifestations include an inability to sit or stand still and a continual pacing and agitation. This can occur in as little as 5 to 60 days following the first dose, and nurses should monitor for an increased risk of suicide in patients with severe akathisia. Tardive dyskinesia is a symptom of extrapyramidal adverse effects. Manifestations include late EPSs, which can require months to years of medication therapy for TD to develop. Involuntary movements of the tongue and face, such as a lip smacking and tongue fasciculations, and involuntary movements of the arms, legs, and trunk. Once TD develops, it usually does not decrease, even when you discontinue the medication, and there is no reliable treatment for TD. Neuroendocrine effects. These are manifested by gynecomastia, weight gain, menstrual irregularities, irregularities, and galactorrhea. Neuroleptic malignant syndrome. This is manifested by sudden high fever, blood pressure fluctuations, diaphoresis, tachycardia, muscle rigidity, decreased level of consciousness, and coma. This is a life-threatening medical emergency. It can occur within the first week of treatment or any time thereafter. The patient needs to stop the antipsychotic medication. Nurses should apply cooling blankets, administer antipyretics, and administer dantrolene or bromocriptine to induce muscle relaxation. Orthostatic hypotension is a complication, as well as sedation and seizures. Severe dysrhythmias can occur. The nurse should obtain a baseline EKG and potassium level prior to treatment, as well as periodically throughout the treatment period. Sexual dysfunction can occur, and it is common in all genders. Skin effects can be a complication, manifested by photosensitivity that can result in a severe sunburn or contact dermatitis from handling the medication. Patients should be educated to avoid excessive exposure to sunlight, use sunscreen, and wear protective clothing. Liver impairment is another complication, and patients should be educated to observe for any indications such as anorexia, nausea, vomiting, fatigue, abdominal pain, or jaundice, and notify those to the provider. Contraindications. Use of conventional antipsychotic medications is contraindicated in older adult patients with dementia. Interactions. Concurrent use with other anticholinergic medications will increase effects. Additive CNS depressant effects can occur with concurrent use of alcohol, opioids, and antihistamines. By activating dopamine receptors, levodopa will counteract the effect of any antipsychotic agents. Nursing administration. Use the abnormal involuntary movement scale to screen for the presence of any EPS. Begin administration with twice daily dosing, but then switch to daily dosing at bedtime to decrease daytime drowsiness and promote sleep. Patients should be educated that antipsychotic medications will rarely cause physical or psychological dependence. Significant improvement can take 2 to 4 weeks and possibly several months for full effects. Antipsychotics, second and third generation, atypical. Our select prototype medication is risperidone. Therapeutic uses include for negative and positive symptoms of schizophrenia, psychosis induced by levodopa therapy, relief of psychotic manifestations and other disorders such as bipolar disorder and impulse control disorders. Complications include agranulocytosis, metabolic syndrome. This can occur as a new onset of diabetes mellitus or a loss of glucose control in patients who already have diabetes. Dyslipidemia with an increased risk of hypertension and other cardiovascular disease, and weight gain. Nurses should obtain a baseline fasting blood glucose and monitor the value periodically throughout treatment. Monitor cholesterol, triglycerides, and blood glucose if weight gain is greater than 14 kilograms. Patients should be educated to follow a healthy, low-calorie diet, engage in regular exercise, and monitor their weight gain. Another complication is orthostatic hypotension, as well as anticholinergic effects, agitation, dizziness, sedation, sleep disruption, mild EPS symptoms such as a tremor, elevated prolactin levels, sexual dysfunction. Contraindications. Risperidone. These medications should not be used in patients with dementia. Use of these medications will cause death related to severe cerebrovascular accident or infection. Other atypical antipsychotic agents. Aripiprazole is a third-generation antipsychotic. It has no or low risk of EPS, as well as low or no risk of diabetes, weight gain, dyslipidemia, orthostatic hypotension, and anticholinergic effects. It does have some adverse effects, which include sedation, headache, anxiety, insomnia, and GI upset. Acenapine comes in sublingual tablets. You should warn patients not to swallow these tablets and instruct them to avoid eating and drinking for 10 minutes after the dosing. Other adverse effects include drowsiness, prolonged QT interval, EPS, and causes temporary numbing of the mouth. Clozapine. This is the first atypical antipsychotic developed, and it's no longer considered a first-line medication for schizophrenia due to its adverse effects. It has a high risk of weight gain, diabetes, and dyslipidemia, as well as a risk for fatal agranulocytosis. Other adverse effects include sedation, orthostatic hypotension, hypersalivation, and anticholinergic effects. Iloperidone has a significant risk for weight gain, prolonged QT interval, and orthostatic hypotension. Some common adverse effects include dry mouth, sedation, fatigue, and nasal congestion. Lurasidone. Some common adverse effects include sedation, akathisia, Parkinsonism, agitation and anxiety, and nausea. Olanzapine has a high risk of diabetes, weight gain, and dyslipidemia. Other adverse effects include sedation, orthostatic hypotension, and anticholinergic effects. Following administration of extended-release injection, the patient needs to be observed for at least 3 hours to monitor for any adverse effects. Paliperidone has a significant risk for diabetes, weight gain, and dyslipidemia. Some other adverse effects include sedation, prolonged QT interval, orthostatic hypotension, anticholinergic effects, and mild EPS. Quetiapine. This has a moderate risk of diabetes, weight gain, and dyslipidemia. Other adverse effects include cataracts, sedation, orthostatic hypotension, and anticholinergic effects. Ziprasidone. This can be used for patients with concurrent depression. For maximum absorption, it needs to be administered with food. Other adverse effects include sedation, orthostatic hypotension, anticholinergic effects, EKG changes, and QT prolongation that can lead to torsades de pointes. Interactions. Immunosuppressive medications, such as anti-cancer medications, can further suppress immune function. Additive CNS depressant effects can occur with concurrent use of alcohol, opioids, antihistamines, and other CNS depressants. By activating dopamine receptors, levodopa counteracts the effects of antipsychotic agents. Tricyclic antidepressants, amiodarone, and clarithromycin prolong QT intervals, thereby increasing the risk of cardiac dysrhythmias. Barbiturates and phenytoin will stimulate hepatic medication metabolizing enzymes, thereby decreasing medication levels of aripiprazole, quetiapine, and ziprasidone. Fluconazole inhibits hepatic medication metabolizing enzymes, thereby increasing medication levels of aripiprazole, quetiapine, and ziprasidone. Nursing administration. Risperidone is also available as a depot injection administered IM once every 2 weeks, and the extended-release injection of paliperidone is administered every 28 days. This method of administration is a good option for patients with difficulty adhering to a medication schedule. Therapeutic effect would occur 2 to 6 weeks after the first depot injection. Administer lurasidone and ziprasidone with food to increase their absorption. The cost of antipsychotic medications can be a factor for some patients. Monitor the need for any case management intervention. Nursing evaluation for medication effectiveness. Depending on the therapeutic intent, effectiveness can be evidenced by the following: improvement and/or prevention of acute psychotic manifestations, absence of hallucinations, delusions, anxiety, and hostility. Improvement in the ability to perform ADLs. Improvement in the ability to interact socially with peers. Improvement of sleeping and eating habits. Chapter 25, Medications for Children and Adolescents who have mental health issues. Various medications can be used to manage behavioral disorders in children and adolescents. Parents should understand that pharmacological management is most effective when accompanied by techniques to modify behavior. CNS stimulants. Our select prototype medication will be methenphenidate. Therapeutic uses are for ADHD in children and adults. Complications include CNS stimulation. The last dose of the day should be administered before 4 p.m. Weight loss related to reduced appetite and growth suppression. Monitor the patient's height and weight and compare it to their baseline height and weight. Consult with the provider regarding giving the patient a holiday from the medication and administer the medication during or after meals. Cardiovascular effects. To monitor vital signs and EKG. Another complication is development of psychotic manifestations, such as hallucinations and paranoia. The medication should be discontinued. Withdrawal reaction is evidenced by symptoms as headache, nausea, vomiting, muscle weakness, and depression. Educate the patient to avoid abrupt cessation of the medication. Another complication is hypersensitivity, skin reaction to the transdermal methenphenidate, including hives and papules. The patient should remove the patch and notify the provider. Toxicity is a complication, presenting as dizziness, palpitations, hypertension, hallucinations, and seizures. Treat hallucinations with chlorpromazine. Treat seizures with diazepam, and assist with the administration of fluids. Contraindications. They are contraindicated in patients with a history of substance use disorder, cardiovascular disorder, severe anxiety, and psychosis. Has interactions with MAOIs, caffeine, phenytoin, warfarin, and phenobarbital, as well as OTC cold and decongestant medications. Nursing administration. Oral tablets should be given 30 to 45 minutes before meals, with the last dose of the day given by 4 p.m. Administer the oral suspension regardless of meals and shake the container for 10 seconds before measuring the dose. Advise parents that full response to medications can take up to 6 weeks. Instruct parents and clients that ADHD is not cured by the medication. Management, in conjunction with an overall treatment plan, includes family and cognitive therapy to improve outcomes. Handwritten prescriptions are required for medication refills. Advise parents that the use of medications will cause a high potential for development of substance use disorder, especially in adolescents. Nursing evaluation of medication effectiveness. Depending on the therapeutic intent, effectiveness can be evidenced by the improvement of manifestations of ADHD. Selective norepinephrine reuptake inhibitor. Our select prototype medication is atomoxetine. Therapeutic uses are for ADHD in children and adults. Complications. This medication is usually tolerated well with minimal adverse effects, but they can occur and would include appetite and growth suppression or weight loss. Encourage children to eat at regular meal times and avoid unhealthy food choices. GI effects. Take the medication with food if GI effects occur. Suicidal ideation. Hepatotoxicity. Educate the patient to report any indications of liver damage, such as flu-like manifestations, yellowing skin, and abdominal pain. CNS effects, such as headache, insomnia, and irritability. Decrease the use of items that contain caffeine, such as coffee, tea, cola, and chocolate. Contraindications. Use cautiously in patients with cardiovascular disorders, and it is contraindicated in patients with suicidal ideation. It can interact with MAOIs, paroxetine, fluoxetine, or quinidine gluconate. Nursing administration. Administer the medication in 1 daily dose in the morning or in 2 divided doses, morning and afternoon, with or without food. Instruct the patient to avoid all use of over-the-counter medications unless approved by a provider. Nursing evaluation of medication effectiveness. Depending on the therapeutic intent, effectiveness can be evidenced by improvement of the manifestations of ADHD. Tricyclic antidepressants. Our select prototype medication is desipramine. Therapeutic uses in children include depression, autism spectrum disorder, ADHD, panic disorder, social phobia, and OCD. Complications include orthostatic hypotension, anticholinergic effects, weight gain related to increased appetite, Sedation. Take the medication at bedtime to minimize any daytime sleepiness and to promote sleep. Toxicity. Decrease seizure threshold. Excessive sweating, so perform frequent linen changes. Contraindications. This medication is contraindicated for patients who have had a recent MI or a history of heart failure or prolonged QT complex. TCAs can increase suicide risk and can be lethal if excessive dosages are taken. Interactions can occur with MAOIs, antihistamines, and other anticholinergic agents, epinephrine and dopamine, alcohol, benzodiazepines, opioids, and antihistamines. Nursing administration. Assist with medication regimen adherence by informing the client and parents that it can take up to 1 to 3 weeks to experience initial therapeutic effects. Full therapeutic effects can take around 6 weeks. Due to the high suicide potential, restrict the amount of medication available to the client. Nursing evaluation for medication effectiveness. Depending on the therapeutic intent, effectiveness can be evidenced by the following. For patients with depression, verbalization of improvement in mood, improved sleeping and eating habits, increased interaction with peers. For clients with autism spectrum disorder, decreased anger, decreased compulsive behavior. For clients with ADHD, decreased hyperactivity, greater ability to pay attention. For clients with OCD, panic, and anxiety disorders, reduced levels of anxiety, increased ability to recognize manifestations and triggers of disorder, ability to manage episodes of the disorder, ability to perform self-care, increased interaction with peers, ability to assume their usual role. Alpha-2 adrenergic agonists. Our select prototype medication is guanfacine. Therapeutic uses are for ADHD, tic disorders, and conduct and oppositional defiant disorders. Complications include CNS effects such as sedation, drowsiness, and fatigue, cardiovascular effects such as hypotension and bradycardia, weight gain, GI effects. Suggest that the patient use the following strategies to minimize or prevent any GI effects: chewing sugarless gum, sipping water, eating foods high in fiber, participating in regular exercise, increasing fluid intake to 2 to 3 liters a day. Contraindications. Safety has not been established for the use of guanfacine or clonidine in children younger than 6 years old. Use cautiously in clients with cardiac disease. Interactions. CNS depressants, including alcohol, can increase CNS effects. Antihypertensives can worsen hypotension. Foods with high fat content will increase guanfacine absorption. Nursing administration. Monitor for the use of alcohol and CNS depressants, especially with adolescent clients. Monitor blood pressure and pulse at baseline with initial treatment and with each dosage change. Medication should be tapered according to a prescribed dosing schedule when discontinuing treatment. Nursing evaluation of medication effectiveness. Depending on the therapeutic intent, effectiveness can be evidenced by improvement of manifestations of ADHD. Atypical antipsychotics. Our select prototype medication is risperidone. Therapeutic uses include autism spectrum disorder, conduct disorder, OCD, and relief of psychotic manifestations. Complications include diabetes mellitus, new onset of diabetes or loss of glucose control in patients who have diabetes. Instruct the patient to report any indications, such as increased thirst, urination, and appetite. Other complications include weight gain, hypercholesterolemia, orthostatic hypotension, anticholinergic effects, agitation, dizziness, sedation, and sleep disruption, and mild extrapyramidal adverse effects. However, these effects are usually dose-related. Contraindications. Be aware of any possible alcohol use in the adolescent client and instruct patients to avoid the use of alcohol. Interactions with CNS depressants. Levodopa, TCAs, amiodarone, and clarithromycin will prolong the QT interval and increase the risk of cardiac dysrhythmia. Barbiturates and phenytoin promote hepatic drug metabolizing enzymes and decrease drug levels of quetiapine. Fluconazole and other medications that inhibit hepatic drug metabolizing enzymes, thereby increasing drug levels of aripiprazole and quetiapine. Nursing administration. Administer by the oral or IM route. These medications can be taken without regard to food. Nursing evaluation of medication effectiveness. Depending on the therapeutic intent, effectiveness can be evidenced by the following. For patients with autism spectrum disorder, reduction of hyperactivity and improvement in mood. For patients with conduct disorder, decreased aggressiveness. For patients with OCD, reduced levels of anxiety, ability to manage compulsive actions, ability to perform self-care, increased interaction with peers, ability to assume their usual role. For clients with ADHD, reduction in hyperactivity and impulsivity. Selective serotonin reuptake inhibitors. Our select prototype medications are fluoxetine, sertraline, and fluvoxamine. Therapeutic uses are for intermittent explosive disorder, autism spectrum disorder, obsessive compulsive disorder, major depressive disorder, bulimia nervosa, and generalized anxiety disorder. Complications include agitation, anxiety, sleep disturbance, tremors, and tension headache. Agitation and hallucinations can indicate serotonin syndrome. Weight changes, GI effects. Contraindications. SSRIs may increase suicidal ideation in children and adolescents, and the dose should be tapered down when discontinued. Interactions. Concurrent use of MAOIs, SNRIs, buspirone, or St. John's wort can cause serotonin syndrome. Nursing administration. Assist the patient with medication regimen adherence by informing them that the initial response will occur in 1 to 3 weeks, with maximum therapeutic effectiveness achieved by 12 weeks. SSRIs can be taken with or without food. Sleep disturbances are minimized by taking the medication in the morning. Report any suicidal ideations to the provider. Nursing evaluation of medication effectiveness. Depending on the therapeutic intent, effectiveness can be evidenced by the following. For patients with intermittent explosive disorder, a reduction of hyperactivity and an improvement in their mood. For patients with conduct disorder, decreased aggressiveness. Chapter 26, Medications for Substance Use Disorders. Abstinence syndrome occurs when a client abruptly withdraws from a substance on which they are physically dependent. Clients who have a substance use disorder can experience tolerance and withdrawal. Tolerance will occur when a client requires an increased amount of the substance to achieve their desired effect. Withdrawal occurs when the concentration of substance in the patient's bloodstream declines and the client experiences physiological adverse effects. Withdrawing from a substance that has a potential to cause abstinence syndrome can cause the patient to experience distressing manifestations that can be potentially life-threatening. Okay, stop that. Withdrawal manifestations. Alcohol. Manifestations usually start within 4 to 12 hours of the last intake in alcohol and can continue for 5 to 7 days. Common manifestations include nausea, vomiting, tremors, restlessness, and inability to sleep, depressed mood or irritability, increased heart rate, blood pressure, respiratory rate, and temperature, diaphoresis, tonic-clonic seizures, and illusions. Alcohol withdrawal delirium can occur 2 to 3 days after cessation of alcohol. This is considered a medical emergency. Manifestations would include severe disorientation, psychotic effects such as hallucinations, severe hypertension, and cardiac dysrhythmias. This type of withdrawal can progress to death. Opioids. Withdrawal manifestations will typically occur within hours to several days after cessation of opioid use. Common findings would include agitation, insomnia, flu-like manifestations, rhinorrhea, yawning, sweating, nausea or vomiting, pupillary dilation, and diarrhea. Withdrawal manifestations are not life-threatening. Tobacco or nicotine. Abstinence syndrome is evidenced by irritability, nervousness, restlessness, insomnia, and difficulty concentrating. Other substances associated with substance use disorder include cannabis, hallucinogens, inhalants, sedatives, hypnotics, and stimulants. Alcohol. Withdrawal. Withdrawal from benzodiazepines. Benzodiazepines will include chlordiazepoxide, diazepam, lorazepam, and oxazepam. We give benzos for alcohol withdrawal to maintain vital signs within reference ranges, to decrease the risk of seizures, and decrease the intensity of the withdrawal manifestations. It can also be a substitution therapy during alcohol withdrawal. Nurses need to administer these medications around the clock or PRN, however they're prescribed. We need to assist with initiating for any seizure precautions. We can give adjunct medications such as carbamazepine, clonidine, propranolol, and atenolol. We give these medications to reduce the manifestations of the withdrawal and decrease any evidence of seizures. We can also depress the autonomic response, which can show a decrease in blood pressure and heart rate. This will also decrease the craving. Nurses need to implement seizure precautions and check the heart rate prior to administration of any beta blockers, and always withhold if it's less than 50 beats per minute. Abstinence maintenance will occur following withdrawal. We can use disulfiram. Disulfiram is a daily oral medication that is a type of aversion or behavioral therapy. When used concurrently with even small amounts of alcohol, it can cause acetaldehyde syndrome to occur. The effects will include nausea, vomiting, weakness, sweating, palpitations, and hypotension. Acetaldehyde syndrome can progress to respiratory depression, cardiovascular suppression, seizures, and death. The first dose should not be administered until 12 hours after the last drink. Patients need to be educated that drinking any alcohol while on this medication is potentially dangerous. They need to wear a medical alert bracelet and participate in a self-help program. Another medication for abstinence maintenance from alcohol withdrawal is naltrexone. Naltrexone is a pure opioid antagonist that suppresses the craving and pleasurable effects of alcohol to prevent relapse in the recovery phase. Concurrent use of heroin with this medication can cause withdrawal manifestations and death. Acamprostate is taken orally 3 times a day to reduce the unpleasant effects of abstinence syndrome. Diarrhea can result from this medication. Opioids. For patients withdrawing and recovering from opioid substance abuse, we can provide a methadone substitution. Methadone substitution is an oral opioid antagonist that replaces the opioid to which the client has a physical dependence. Methadone administration will prevent abstinence syndrome from ever occurring, and it removes the need for the patient to obtain illegal opioids. The dependence is transferred from the illegal opioid to the methadone. We want to encourage the patients to participate in a 12-step program and inform them that the methadone dose needs to be slowly tapered in order to produce the detoxification. Clonidine can assist with opioid withdrawal effects related to autonomic hyperactivity. We need to monitor for manifestations of opioid withdrawal, which would include elevated vital signs, nausea, vomiting, diarrhea, yawning, running nose, and goosebumps. And we need to educate the patients to avoid activities that require any mental alertness until their drowsiness subsides. Naltrexone is a medication that can be used to prevent relapse after opioid detoxification. Buprenorphine is a medication that decreases feelings of craving and can be effective in maintaining compliance. Antidotes. Naloxone is a specific opioid antagonist. This can be given IM, sub-Q, IV, or inhalation to reverse respiratory depression, coma, and other effects of opioid toxicity. Flumazenil is a competitive benzodiazepine receptor antagonist. This can reverse sedative effects and toxicity, and it needs to be administered IV. These are both used in overdose situations. Nicotine. Bupropion can decrease nicotine cravings and manifestations of withdrawal. Patients should be educated to avoid caffeine and other stimulants, CNS stimulants, to control their insomnia. Nicotine replacement therapy can occur in the form of nicotine gum, nicotine patch, nicotine nasal spray, nicotine lozenges, and a nicotine inhaler. The intended effect is that the nicotine replacements are a pharmaceutical product that would substitute for the nicotine in a cigarette or chewing tobacco. The rate of tobacco use cessation has nearly doubled with the use of these nicotine replacements. Patients should be educated to avoid the use of nicotine inhalers in patients when they have asthma, and they need to gradually taper this nicotine inhaler over 2 to 3 months and then discontinue it. Nicotine gum needs to be chewed slowly and intermittently over 30 minutes. It's not recommended for longer than 6 months. A nicotine patch should be applied in the morning and removed 16 hours later at bedtime. Nightmares or sleep disturbances have been reported when patients wear their patches throughout the night. Nicotine spray. 1 spray in each nostril will deliver the amount of nicotine in 1 cigarette. Nicotine lozenge. Limit your lozenge use to 5 in a 6-hour period or a maximum of 20 per day. Varenicline. This is a medication that can reduce cravings for nicotine as well as the severity of withdrawal manifestations. It will also reduce the incidence of relapse by blocking the desired effects of nicotine. Nurses need to monitor blood pressure during treatment, and due to potential adverse effects, varenicline is banned for use in patients who are commercial truck or bus drivers, air traffic controllers, or airplane pilots. Patients should be educated to monitor for some neuropsychiatric effects, such as unpredictable behavior, mood changes, and thoughts of suicide. And they also need to be educated that this medication can cause mild to moderate nausea. Electronic cigarettes, or e-cigarettes. The use of electronic e-cigarettes should be discouraged due to their dose of nicotine being unpredictable, and data on safety and efficacy are lacking. Nursing evaluation of medication effectiveness. Depending on the therapeutic intent, effectiveness can be evidenced by the following: absence of injury, ongoing abstinence from the substance, regular attendance of a 12-step program, decreased cravings for substance, and improved coping skills to replace the use of that substance.